Hi, like I started to say before, we have to worry about things with basic principles of pharmacology like pharmacokinetics, pharmacodynamics. So pharmacokinetics can change, but pharmacodynamics cannot, right? So what are pharmacodynamics? That is what the drug does, right? Pharmacokinetics, it affects your bioavailability, and anytime you have bioavailability, it has to do with absorption, distribution, metabolism, and excretion, right? So pharmacodynamics never change. That's what the purpose is. Lasix always acts like Lasix, right? It has a definite job. It's a diuretic. Pharmacokinetics, this is how I always remember the difference. It's kind of dumb. It's what it does to your kin, right? What it does to you. Um, so it affects what it does to you. And that is ever changing. It has to do with your gender, your age, your body type, your ethnicity, all kinds of things like that. So just remember, kin pharmacokinetics changes, and it always affects bioavailability, where pharmacodynamics never changes. The drug, we have to trust the drug does what it says it does. Okay? That's a piece about that. And I did put out that content sheet with terms and things in week one. Just read over that. That's stuff you need to know. It's not necessarily for the exam. It just puts all the other pieces together. So anyway, drugs that have a significant first pass effect. Significant means it flies through quickly. The drug metabolizes quickly. You excrete it quickly. What does that mean? So whenever somebody says, oh, it has a significant first pass effect, means it goes through the stomach and goes through that liver really fast. That's what that has to do. You may get little or no desired action of that drug if that happens. So once again, I know there's a lecture that I had talked about cytochrome for P450 isoenzyme. That also has to do with first pass effects. So say if you give a drug, I'm trying to think of an example, certain drugs you give together may cause it to go through may cause it to go metabolize quickly or slowly. So those are things that affect first pass effect. So when somebody says it has a significant first pass effect, it goes through rapidly through your liver and you may not get the desired action of the drug. And I've repeated that twice now, so you might need to know that. Then there's other things too. I think your book's focused on drugs with storage drugs. I know you had to read that at one point. Let me see if I pulled this up at all. I may not have. So a storage drug is a drug that's similar to, like, let's see, what's an injection that lasts a couple months? How about Depo-Provera? We give Depo-Provera. It provides birth control coverage for 3 months, right? Well, when you give that drug, it's a storage reservoir drug, and it's in like an oily material. So why would we give something like that? Why would we have a drug that we put in this oily material and call it a storage reservoir? Well, the reason for that is it increases length of time the drug is available and active. So Depo is a great example of that. I'm trying to think of another one, but there's obviously more than just Depo. But as far as that goes, that's the purpose of a storage reservoir drug. It increases the time the drug is available and active. Okay, so let's see. You're going to choose a drug that you're going to give every 8 hours or every 12 hours or every 4 hours. And why would you choose that drug? Because you're going to know the biological half-life of the drug. We've all seen that. Let's give an example. Let's see, hyperlipidemia meds are given once a day because they have certain half-lives. Although Lipitor has a shorter half-life than a Crestor. That's why Crestor can be given at any time of the day, and Lipitor can only be given at night. So here we go. So to choose a drug for every 8 hours or 4 hours, whatever you're dosing, you're choosing the drug based on that biological half-life. You're going to cover that person the whole day. So a lot of times you'll pick a drug where a once-a-day drug like a Levaquin has a very, very long biological half-life. But a drug like Keflex, say, has a short biological half-life, and you may need to give that drug every 8 hours. So that's why you're giving drug. You need to have a knowledge of that bioavailability and the half-life. Okay, so let's talk about drugs with loading doses. Your Z-Pak, it requires that you give a loading dose, doesn't it? You give a loading dose, you give those two 250 milligram tabs on the first day, and the remainder of the 4 days you get once. You give one pill, right? Because you've given that loading dose. So what does that mean? What is a loading dose for? It brings that drug level right up to that therapeutic range immediately. So that is the purpose of a loading dose, to bring the drug, to bring that drug level into therapeutic range right away. And that's why it works so well. Let's see. I know we've all seen under the curve and above the curve, that lovely curve that's really kind of hard to understand. And that has to do with peak of action, onset of action, and therapeutic ranges. Let me scroll down here. I don't know if we even have that on this slide. Onset of action, here we go. So the onset of action is the time between administration and first sign of the drug effect, okay? And that's what that means. This is the point in the time where the drug concentration curve indicates the first sign of the therapeutic effect. Of course, we don't see that. It's an imaginary curve, but that's what it is. It's always important to know peak of action, duration of action, and termination of action as well. But the onset of action is the time between the administration and the first sign of the drug effect. All right, let's see where else we are here. Okay. There's something else we need to talk to too. It's drugs that need a peak and a trough level, and why do we do that? The reason we draw troughs, of course, and peaks, but usually troughs, is to see if the drug is in the therapeutic range. So always keep that in your mind. So gentamicin, vancomycin, tobramycin, phenytoin, things like that all have peak and trough levels. And the reason we do that is to determine if the drug is in therapeutic range. Those are always important to know too. Let's see. Once again, I went through this whole thing about first pass metabolism, and you need to know that. Drugs with significant first pass effect require either increased dosing or administration being another route, such as IM or IV. Significant first pass, once again, are quickly metabolized by the liver. Back to bioavailability too, I think everybody realizes that if you've given something intravenous, it's immediately bioavailable. There is no bioavailability issues when you're giving something IV. So bioavailability really has to do with PO meds. IV, like I said, it's right there, it goes right to the target. You have no problems whatsoever. So most drugs, of course, if you have somebody really sick, that's why you're sending them off to the hospital for IV medications. When you have, so bioavailable, what I just said, bioavailable issues really come into play when you have somebody with a drug that has a very low therapeutic range, or if they have sustained release. So low therapeutic range drug would be digoxin. Phenytoin's pretty low also, but theophylline is another one. It has a very low, a narrow therapeutic range, and those are the drugs that you really need to be careful with. Let's see. Okay, I know everybody's heard of the blood-brain barrier, of course, and we have placental barriers, fetal placental barrier. So, what do you think is true? Does the blood-brain barrier slow the entry of many drugs into the brain cells? Do you think that's true? Or does the fetal placental barrier protect the fetus from drugs taken by the mother? That's definitely not true. A lot of things do cross the placenta. The blood-brain barrier does slow the entry of many drugs into and from the brain cells. So that's a really important thing to know too. Lipid-soluble drugs cross the barrier very slowly. Slows the entry of many drugs. So blood-brain barrier is relatively impermeable, usually protective. So you need to know about that as well. Let's see, placental barrier. you know it's there, but a lot of things do pass. Many things pass. Low molecular weight drugs pass easier. So if you have somebody pregnant, you're really careful what you give them. You're always looking for that pregnancy X. Try to only give pregnancy B categories. Sometimes that's not possible. C means they've not really been tested, and it's kind of scary. So steady state is another thing that is on that content 1. What does steady state mean? Steady state, rather, I'm sorry. So that's when the amount of the drug in the body remains constant, steady state. So I figured I'd throw some terms in there because you might need to know those terms. So if you were going to give a medication sublingual, do you think that's a good way to give a med? And it absolutely is. What happens with sublingual medications under the tongue? Think of a nitro. If you have to give a nitro really fast, absorbs really quickly. Sublingual is another great way to increase bioavailability because sublingual medications absorb quickly. Let's see. I'm trying to decide. Once again, it gets into factors that influence metabolism. I think I spoke about this before. Gender, fat, things like that totally affect metabolism. Let's see here. Here we go then to just to touch. Like I said, I'll give you a whole entire lecture on this in week 4, which you won't be responsible to answer any questions. That'll be after your test. You'll go home during the week and click on and listen. You won't need to do that prior to your test. But it's cytochrome P450 isoenzyme. You'll see all these numbers, and you're going to see these in all your drug apps as well. It'll say it might be a cytochrome P450 isoenzyme substrate 2C9. So you'll learn what all of that means later, not today. Okay, genetics and prodrug. I don't think elimination. I'm trying to think if I have any more on this slide to talk about, in this PowerPoint to talk about for your review. GI tract. I think we're getting pretty close to being done. Salivary, nothing. Good, we're good. This one is breast milk though, and this is just a sidebar. You're going to have patients in your practice that come in and may be breastfeeding. You want to really make sure that it's a smaller molecular weight drug that you're giving. There is a great resource called Hale's. It's called Hale's Mother's Milk. Actually, you need to have that in your primary care office just in case you have these patients come in, and you can find out what somebody who's breastfeeding can and cannot take. So, once again, the big take-home points too are when you're prescribing drugs to kids, pregnant women, you need to be really careful because there's not a lot of studies. So you also need to pay attention to rational drug selection. What's going to cause you to prescribe something maybe to a kiddo? Maybe you're going to get liquid form instead of pill because kids may have trouble swallowing pills, things like that. Cost is always in mind. And if you're deciding on multiple drugs to treat a condition, what are you going to do? You're going to be, you're always going to see if you can cut down the amount of time somebody takes it and the drug they can take at home. You don't really want to be giving you don't want somebody running for a 24-hour IM shot in the pediatrician's office for an ear infection if the baby can take something oral. Or so the goal is you want to make sure that when they come into your primary care office, one of the other things is that you can prescribe a drug that they can take at home and not too many times a day, maybe twice daily. That is part of rational drug selection as well. And we talked about the differences in fat and genders for how things are, how pharmacokinetics, the difference between men and women. Remember, kin, what happens to you, not what the drug does, but how you metabolize it, absorb it, or excrete it. So fat definitely does, genders definitely does. And actually, The World Health Organization, before we can prescribe anything, they recommend that we diagnose the patient correctly with the problem that they're having. That would be a big disaster if I think that I have somebody with strep throat that really is having, well, strep throat's probably not a great example, strep throat, but they really are just ill with something else. You want to make sure you're making the correct diagnosis before you treat anybody. When you're treating people, you want to make sure that your patient is really involved with their care as well. And I think that we've all learned that as nurses. You don't ever exclude them from the treatment plan. You want to make sure that it's always patient-centered. So by patient-centered, I had somebody the other day and they're like, I just cannot handle, she had terrible sinus infection and she said, I cannot handle the diarrhea that Augmentin causes. So I changed my drug. She wouldn't have been compliant with it. That's the other thing. If it's patient-centered, your compliance rate goes way up. So what are your goals? What are your goals to treating somebody, like therapeutic goals? We still have goals, right? No matter if we're nurses or nurse practitioners. You want to make sure that everything you're prescribing is either curative, palliative, or preventative. Curative meaning you're going to cure the problem, palliative meaning you're going to make their life a little easy, or preventative meaning you're going to stop something from happening. So let's do an example. A curative would be an antibiotic, right? Palliative, something that makes their life a little better, might be a Mobic for arthritis. It's not curing anything, but it's making your life better and easier. And how about preventative? That could be your immunizations, or it could also be like a vitamin D supplement for osteoporosis. So you want to make sure all those things are. So you always want to individualize your drug choice for every patient. Like I said, this patient wouldn't have taken Augmentin, so I needed to do an individual thing. Always, always, always. And cost, always remember cost, cost, cost when you're individualizing your treatment plan for your patient. You always want to worry about your patient education when you're prescribing, and you always want to make sure that you can either show them somehow. I know they get the pamphlets from the pharmacy about the adverse side effects, but you need to tell them short and sweet what they can expect to happen. Yes, this causes diarrhea. Yes, you need to take a probiotic. Yes, you may have some dizziness. With their fluoroquinolones, yes, this could cause tendon rupture. You want to make sure that they are well informed of all the adverse drug reactions. Mostly the expected ones, which are minor reactions, rash or diarrhea, but you want to go as far as also telling them some of the bad ones that can happen as well. And let's see. And you want to, whenever you're, some of the pharmacokinetic factors that affect how you prescribe something would be the bioavailability. Is it a man? Is it a woman? Are they fat? Are they thin? Are they old? Are they young? So those are all pharmacokinetic factors. Know the difference between pharmacokinetics and pharmacodynamic. Remember, dynamic has to do with what the drug says it is. Pharmacokinetic is what you do with it. Your body does with the drug. Can't drive that home enough. That'll help you answer several questions if you know that, you know those answers. The other thing you need to know is there's something called passive drug monitoring of the effectiveness. So there's actually phone numbers and websites where you can actually have your patient report an adverse reaction, but your patient needs to report to you if the drug is not effective, and then you need to report it as well. I'm trying to think, it's usually something that's being used off-label and you've tried it and it's not working. Remember, once again, to use something off-label, there has to be several studies, at least one study done before you can use that drug off-label. We'll get to that later. So what if you have somebody coming in that's promoting your drug and wants you to, say you have a pharmaceutical rep that's going to bring you a nice lunch and they want you to promote their drug. What do you need to do? There's been recommendations by the Institute of Medicine. Conflicts of interest in financial relationships always have to be disclosed when you're giving any kind of, when you're providing education. So pharmaceutical rep, even though he brings you nice lunch, he has to make it clear that he's not going to get something out of this. So always worry about the conflict of interest as well.